Okay, so the topic today is COVID, and I'll talk a little bit about COVID in general, in addition to talking about type 1 diabetes. So I think it's important to start off with what is COVID-19. I feel like there's so many terms thrown around that sometimes it's hard to know what's what, but COVID-19 is short for coronavirus disease 2019, and that's caused by the virus SARS-CoV-2. So COVID-19 is really the clinical illness that results from the SARS coronavirus, and it's labeled number 2 because there was one prior. It just wasn't as significant, causing a pandemic. I think it was in 2010. So this is the timeline of what has happened with SARS-CoV-2. It emerged in China in late 2019, and human-to-human transmission was confirmed in early 2020. And then very quickly, a public health emergency and a global pandemic were declared national emergency. And then here, I know we have people from Texas and Idaho, and I don't know if anywhere else, but I do have some information that's Colorado specific. In Colorado, March 18th is when schools were closed and a safe at home order was put in place from March to April. And then really restrictions were in place until July in Colorado, which will be important when I'm showing you some data later. And so we have the original strain of COVID-19, and now we have 5 other variants that have emerged. And I wanted to throw this in here because it's a hot topic now, because people are saying, well, what does this mean? Are these variants more lethal? Are they more transmissible? Will the vaccine work on these variants? And so I have all the information here, but I think what's really important to know is that a lot of the variants are already very widespread. There's a couple that aren't, but the goal of a virus is to be able to infect more people and to live. So it wants to become more transmissible, but it doesn't really want to become more lethal because it wants to keep people alive so that it can keep replicating. So hopefully that's the case. The UK variant, there's somebody who has said that maybe it's more lethal. I think that still isn't quite borne out. And it does look like a lot of them are more transmissible right now, meaning that more people can be infected. And so far, it looks like the vaccines that are available will work. They may not be as effective as they are against the original strain or the original variant strain, which is here on the right, but they should work somewhat. And likely COVID will be like the flu, where every year there will need to be a new vaccine eventually. So, viruses don't mutate unless they replicate. And so it's just really important as we're talking about this to think about how can we keep viruses from replicating. And that means doing all of the things that I'll talk about, like wearing masks and also getting vaccinated when that's an option. So how does SARS spread? And I really like this graphic because everyone's always saying stay 6 feet away and socially distance. And it's like, well, why? What is the magic 6 feet? But when you look at this graph, it shows that if somebody coughs, that droplets typically travel about 6 feet. And so COVID-19 illness is most commonly spread between people when they're in close contact, 6 feet or less, because most of the time people are just exhaling normally, talking normally, coughing. However, if you're around somebody who is sneezing or singing, so forcefully exhaling, then you can see that those droplets can travel further. And so 6 feet is a general rule, but you're certainly not completely out of risk if you're 8 feet away, 10 feet away, depending what's going on and how many people you're around. And so those droplets are inhaled into your nose, mouth, airways, and can cause infection. They can also enter through the eyes and cause infection. And then lastly, they can drop on surfaces. And so if they dropped on surfaces and you touch the surface and then you touched your eyes or licked your hand, then you could potentially get the virus, but that's not the main way that it's transmitted. So as long as you're washing your hands, the main way is really droplets in the air. And so what does this virus do in our bodies? Well, the virus is this nice little spike protein we see here. It has all these nice little spike proteins on the outside. And then it goes to all of our tissues that have what's called ACE2 receptors. And ACE2 receptors are in a lot of different tissues, actually including the beta cell in the pancreas that makes insulin, but they're most predominant in your nose and your tongue and oral mucosa and your heart and your lungs and your colon. And so when you think about the symptoms that people have when they're infected with COVID, it makes some sense when you think about where that virus is able to attach to a receptor and go into the cell. And so this is an overview of the symptoms from the World Health Organization. So if you look at the orange, those are listed as the most common symptoms: fever, cough, tiredness, and loss of taste or smell. I will say that fever is actually pretty rare. And so a lot of places don't necessarily, check temperatures anymore, but it is still listed as a common symptom. Less common symptoms can be things like sore throat and headache and aches and pains and diarrhea and rashes on the skin or red or irritated eyes. And interestingly, and we'll talk about this later, but a lot of the less common symptoms of the actual illness are more common with vaccination. And then the serious symptoms are the things that we all hear about that we get scared about. So having trouble breathing, feeling confused, and maybe not being able to think clearly, or having severe chest pain. And it's important to know that the studies that are out there show that somewhere between really mostly 30 to 50%, I've seen 20% too, of people infected with this virus don't have any symptoms. So people can be walking around, but can still spread the illness. And that's why it's really important to, if you're, for public health measures, to kind of assume that everybody could have it. And so what are the risk factors for severe illness? And this was taken from the CDC. And on the left are the illnesses or the medical conditions, or I guess just characteristics that cause increased risk if you're infected. Really the most important one is age. And then you can see a number of other things listed there, including immunocompromised state from a solid organ transplant because people are on immunosuppressants. So remember that with type 1 diabetes, it's an autoimmune disease, but it doesn't mean you're immunocompromised. And then being obese, so a BMI of 30 or more, and then type 2 diabetes. And this is important because the CDC's recommendations for vaccination on a nationwide level use the increased risk category for when they think vaccine should go next to people. So the CDC currently has type 1 diabetes on a national level in the possibly increased risk category. And then this is just a quick picture of COVID in the United States. So if we're looking on the left, this is a recently updated graph kind of showing where we're at with cases and deaths. And I think by this point, most of us know someone who's probably been infected, and sadly, probably someone who hasn't had a good outcome from it. I think at the beginning it was harder because, you see these big numbers, but you don't necessarily know anyone that's had a bad outcome from it, because most people don't. Most people feel okay and do okay. But when enough people get it, enough people get sick. And I think the middle graph represents that really well, because it's a map showing where the total cases are, and they actually have a graph showing the total deaths as well, but I didn't put that on here because it's essentially the exact same. So where you have more cases, you just have more death because it's just a percentage of how many people get sick. And so the goal really is to, prevent the spread. And then on the very right, you can see a heat map where it's looking at per the population in whatever area in the United States you're in, how many people have a bad outcome. And so you can see that on the Maine and on the I guess that's in Oregon and Washington, not as many people have been infected as kind of a lot of the Midwestern areas. And then this is just some data from the Barbara Davis Center. So we have looked through charts and looked for anybody who has reported having COVID, or for any tests that have been done through labs that we're connected with. So there's definitely a bias in that we are very much under capturing probably people that have had COVID, because not everyone's reported, not everybody's in our system, and a lot of people are probably asymptomatic. But so far, what's been reported is what you see here, 100 and I believe it's 23 it's covered right now, the number is, but 40% of those were from our pediatric clinic and 60% from our adult clinic. And you can see that it really just mirrors the United States, where cases increased in the fall and winter. And then looking at the pediatric cases in our clinic, so we had not only the ones that I just showed you that were PCR confirmed, but also 39 that were self-report. So right now we've identified 88 cases, and again, this is very much biased, but of those that we know have had COVID, 10 of those were in DKA, so a little over 10%. But the really important thing to see is that only one patient who was in DKA had a hemoglobin A1C less than 10%. I think it was 8.1%, something like that. But the rest all had very high A1Cs, so we're not in that great glycemic control. And we know that with any illness, kids and adults who aren't having good glucose control are at higher risk for going into DKA with an illness or anything that stresses their body. And then on the right, you can see the breakdown of the patients that had COVID and kind of what their racial background was. And you can see that it's disproportionately affecting, just like it is everywhere else in the United States, it's affecting non-Hispanic whites less and other racial groups more. So before COVID, we knew that some information about infections and type 1 diabetes. We know that people with type 1 diabetes, really, I think mostly related to poor control though, are more likely to have infections. And we also know that children and adolescents that have hemoglobin A1Cs at target levels that we recommend or close to them do not really appear to have an increased risk of infections. And we also know that infections in people with type 1 diabetes may trigger DKA. And having a high A1C, so kind of being on that borderline of ready to make ketones at any time, and having being of a minority race or ethnicity are risk factors for developing DKA. And so what is known about COVID and in people with type 1 diabetes? And so it's interesting because there was a review article published, well, it was published online in, I think, December, but isn't going to be in print next month. And it's, you know, the disease has only been out a year and there's already a review article, but it was useful. But there were 21 reports talking about COVID-19 infections and diabetes, and 7 of them were kind of focused on how often does it happen, what are the outcomes when people are infected, and what does that look like. And then most of those were smaller studies. 2 were in the US, 4 were from Europe, and 1 was from Saudi Arabia. And the one in the UK is the one that has gotten the most press, and we'll talk about that one in a little bit more detail. And then the other studies looked a little bit at COVID at the time of diagnosis of type 1 diabetes, and also outpatient management for patients who have type 1 diabetes during the pandemic. And then since that review, in December of last year, there was a prospective study published. So basically there was a healthcare system that had, I think, about 120 or 30 sites where they prospectively identified people who tested COVID positive and then matched up type 1 diabetes versus not type 1 diabetes and followed to see how they did. And so we'll review that study too. So first study to talk about is this United Kingdom study because it's the first one that came out and kind of got people nervous. So what it looked at is it looked at a bunch of people in the United Kingdom. So it looked at everyone in the healthcare system. You can see there's 61 million and some people. And then looked at how many people had type 1 diabetes. So that was 263,000, a little over. And then what they did is they looked at hospital deaths and they tried to figure out, they did a really simple analysis and they showed that if you have type 1 diabetes, your odds of having a death from COVID in the hospital were 3.5 times higher if you had type 1 diabetes and 2 times higher if you had type 2 diabetes. So I think that was pretty shocking for everybody. And this is a graph from the paper. I think the important thing, or table I should say, the important thing to see from here is kind of what I have highlighted in that gold box. And it's that they didn't have any cases under 50, or they may have had like 1, but not enough to actually run in any sort of statistical analysis. And just like in anyone else, in any other population, as you get older, the risk of having a bad outcome increases. And then this is the graph from the paper. And I think when you just look at it, it does look fairly alarming. The red line is people with type 1 diabetes. And so it's basically looking at type 1 in red, type 2 in the dark blue, and then the overall population in light blue. And you can see that it looks like people with type 1 diabetes, especially as they age, are at increased risk compared to other people. But the one thing that is really important to know is that within this kind of really rudimentary analysis, they didn't account for any of the other comorbidities that can occur with or without type 1 diabetes, but can be related to poor outcomes with COVID. So things like obesity and hypertension and chronic kidney disease and things like that. So it's a little bit hard to know for sure if that's really all type 1 diabetes. And then this is from the actual review paper, and it's kind of looking at the two other main studies that were trying to identify the factors that were associated with not doing well and having, in the one paper, the Holman paper in the middle column, having an outcome of dying, and in the Coronado study, an outcome of being having to get help with breathing or dying. And so you can see that when you look at male sex, it looks like that's a risk factor because anything over 1 as a hazard ratio is a risk factor, only in one study, not in the other. You can see the older age is clearly the most important thing, a hazard ratio that's much over 1 in both studies. And then BMI is also relevant in both studies. So having a high BMI, and then in this paper, it also showed if you have a low BMI, so not enough weight for how tall you are. And then hemoglobin A1C, in one study, it showed that it was correlated with a poor outcome. In this study, it did not show that. And then having a previous heart attack or a stroke were both correlated with not doing well. And smoking in one study was correlated with not doing well. And again, this was only 56 people in a retrospective analysis. This one was a little bit more. So this was from the UK data. So I wanted to just take a minute and look at A1C specifically. So when you look at this line, basically is looking at the odds of not doing well, or having an increased risk of not doing well, or having a decreased risk of not doing well, so doing better. And so you can see that at a really low A1C and at a really high A1C, it shows that you don't do better. Now, I think that this is probably, again, you always have to look at the data and think, right? Because just having an A1C less than 6.5% doesn't mean that you're going to do more poorly. This means that some people that have A1Cs that low have a lot of low blood sugars, and low blood sugars and high blood sugars are independently associated with not doing as well when you are sick enough to be in the hospital. So I think that's what that is reflective of, but clearly really what we're most concerned about is these high A1Cs. And so this graph on the right is just to kind of remind everybody that you want to, if you're wearing a continuous glucose monitor or checking your finger more than 4 times a day, you want to have blood sugars between 70 and 180 more than 30% of the time for sure. And if we can get closer to the 60-70%, then you're probably protected from A1C causing DKA or a bad outcome with COVID. Okay, so and then this is the last study I was kind of alluding to, the Gregory study, where it was prospective. So they looked in their healthcare system and followed people. And this graph shows people without diabetes in the red, people with type 1 in the green, and people with type 2 in the blue. And it's looking at the probability of being hospitalized by age. And so you can just see that as people get older, the likelihood of being hospitalized increases, whether you have diabetes or not. And once you get to 75 or so, the no diabetes and the type 1 diabetes kind of intersect. So the paper also looked at trying to figure out what factors are associated with worsening illness. So if you have a positive COVID test, what predicts that you would get sicker within 14 days of that test? And so this did show that type 1 diabetes predicts that you would get sicker. And it also showed that all of these other things listed here have some impact. So a high BMI again, smoking, high blood pressure, being male, being an ethnic minority, and having type 2 diabetes as well. And then when we look at this graph, this is a graph trying to show what are the predictors of severe disease. And you can see that age and diabetes status are kind of the biggest predictors, but it doesn't differentiate here between type 1 and type 2 diabetes. So I think a couple things important. In this graph, it doesn't distinguish between type 1 and type 2. And in this middle graph, they don't control when you're looking at type 1 diabetes. This isn't adjusted or controlled for any other factors. So again, is it really type 1 diabetes, or is it other things that are causing it to look like it's so high. So if you happen to get COVID and have to be hospitalized, which usually is in older individuals, I would say over 50, increased risk, then high blood sugars, low blood sugars, and having variability in your blood sugars are independently associated with not doing as well when you're in the hospital. And so treatments for COVID right now, some of them may actually make it harder with diabetes. As we know, or many of us know, steroids can make blood sugars higher and can necessitate the use of an insulin drip, which is really complicated when you're in isolation in a room and people are trying to limit their interactions. So it can cause some problems. Remdesivir, which is a drug that has been under investigation for COVID-19 treatment, can cause liver injury, and that can complicate diabetes management if your liver is not able to store and release glucose like normal. And then there's also some protease inhibitors that typically have been used for HIV and are being studied for COVID-19 that have been associated with increased insulin resistance and hyperglycemia. So the medications that are used right now or are under investigation can have some effects in people with type 1 diabetes. So really, anyone with type 1 in the hospital would need to be closely monitored and have frequent adjustments in their insulin dosing and drips. So kind of moving on to the other area, one of the other areas is new onset diabetes with COVID. And when patients were hospitalized with the initial coronavirus in 2010, there were some patients reported that experienced high blood sugars that persisted for at least 3 years, and even in patients who didn't have pre-existing diabetes. And the current coronavirus shares 79% of its genetic sequence with that virus, and so the thought is that it might also have a direct impact on beta cells. There's been a case report of a 19-year-old who did not have antibodies but had type 1 diabetes with undetectable C-peptide, or really no, they weren't making their own insulin, and that happened 5 to 6 weeks after he had a COVID infection. And so there's been a global registry that's been developed to kind of follow this and see if it's a real thing. Overall, the rate of type 1 diabetes diagnoses, though, have been really similar to prior years. I think we thought at first that they might be increasing due to this, but they've really remained stable throughout the United States. And so this is just kind of showing some data from the Barbara Davis Center, which I think is really interesting. This is showing the rate of DKA during the kind of the lockdown. So lockdown happened in March, and we came out of lockdown in April, and then restrictions were still in place till about July. And you can see that the 2 years prior to the pandemic, this is the rate of DKA, which is still really unacceptably high, you know, anywhere between 45 and like 57%. But during the lockdown, you can see that the rates of DKA were well above 65%, almost that whole time. And so we saw some really sick kids, and that's just because people were probably scared to access healthcare during that time. And once things opened up a little bit more, then the rates of DKA became more similar again. And then this is just what I have already mentioned, but this is just showing our average new onsets in each month, the 2 years prior to 2020 and then during COVID. And so if you kind of look, they're actually very similar, and there's no statistically significant difference between the number we saw each month in 2020 compared to the prior years. And then the last kind of thing that there are papers on is type 1 diabetes management during the pandemic. And there's been quite 2 studies showing that glycemic control was better. And the thought is maybe it's because there's a more regular schedule and reproducible meals and time to kind of think about diabetes. And then there was one paper from India that showed worse control, and the thought there was just that they were in an area where there was decreased availability of supplies for diabetes. So I think it's just somewhat dependent upon your situation. Access to supplies is important. And so luckily there haven't been during this whole time any reports of direct impact from the pandemic to any diabetes products or supplies. So I think that's just super fortunate. I think it's still important to know that renewing and refilling prescriptions before you run out is important, because you just never know when things will happen or when restrictions will change, or, you know, if anything changes. And so making sure that you have prescriptions current, that you have the max number of refills available, thinking about backup medications if you're on a pump and it fails, you know, what would you want to have at home? You may be able to get mail order if you don't usually do that, so that you can have more supplies on hand at once. And your pharmacy can often fill in advance if you request that. And then there's also a list that this, you can either search it, or hopefully this hyperlink will work if I share this, but there's America's Health Insurance Plans published a list of basically every individual insurance plan and what they're doing to help in the pandemic, whether that's, you know, no copays for telehealth visits, or giving $100,000 to, you know, some healthcare system in Ohio to support certain visits. But there's a lot of things that insurance companies have tried to do to kind of help people during this time. And then I think it's really important to know that if you can't find insulin, getinsulin.org is a new program where that shows anybody, whether you can get insulin or not, kind of the cheapest way to get insulin. And it's just really helpful for people who are uninsured especially. So kind of in summary of all that information, there's been multiple studies identifying type 2 as a risk factor for hospitalization and poor outcomes, but really with type 1, I think it's not well known, and especially in kids, we have no reason at all to think they would do worse, either contract COVID more or do worse with COVID than anybody else, and in young adults as well. Patients with pre-existing type 1 diabetes and COVID often present with high blood sugars and/or DKA, and hospitalization rates are really similar for people with type 1 diabetes compared to the general population. And then the risk of bad outcome may be increased like we talked about, but again, I think that's mostly in older individuals if it's real. And then the new onset type 1 diabetes rate is really stable, but DKA at new onset appears increased. And a change in glycemic control may or may not be happening. It's probably pretty individual. So given all of this, nobody wants to chance it, right? So nobody wants to see what happens if you get COVID. So how do you protect yourself and others from getting COVID? And so one of the main ways is to physically and socially distance. And so that means maintaining that 6 feet from others, further when indoors, and the further the better. And I like this graphic because it kind of shows, what does that mean? Well, if you're looking at floor tiles are usually about 1 foot wide. If you're standing, a bed is usually about 6 feet long. And then a dog's leash is usually about 6 feet, a standard dog's leash. So if you're out on a walk, you can kind of judge. And then a sedan, if you're on either side of that, that's about 6 feet wide. And if you're in a grocery store, 2 shopping carts. So, you know, thinking not 1 shopping cart and then you're up right next to it, you want to have that 2 shopping cart distance. And then wearing a mask. So these are just a picture kind of showing the right way to wear your mask. You want to make sure your nose is covered, your chin is covered. You don't want to have gaps if possible. You don't want to be touching and moving your mask up and down and all around. You just want to kind of leave it on until you're done and then take it off and wash it. And you don't want to use a wet, dirty, or damaged mask. And you also don't want to use a valved mask. So if you use a valved mask, the masks that have a little circle, you might be protecting yourself the little bit that your mask can protect you, but you are not protecting anyone that you are around, which is one of the main reasons we wear masks. So it's important to realize that. And then just avoiding the 3 C's, spaces that are closed, crowded, or involve close contact. So keeping rooms well ventilated, opening windows, just trying to increase natural ventilation. And I think this is kind of a nice graphic to look at on the left because it shows how contagious is a disease, and there's something called an R0 that scientists or public health people actually talk about. And the R0 for COVID-19 is 2 to 2.5, meaning that 1 person can infect 2 to 2.5 people. And you can see that like measles is 11 to 18. It's way more contagious. But then you can see the seasonal flu is about 1.3. So COVID's more contagious than the seasonal flu is. And then lastly, just washing your hands. So, you know, getting wet, getting soap, scrubbing for long enough, 20 seconds. I see over and over, they say sing happy birthday. And in our house, I thought that would just be like, it would make birthdays not special anymore. So we sing row, row, row your boat, which is a song I'll probably never want to hear again after 2021. But if you sing that 2 times, then you wash your hands for 20 seconds. So this is a map just showing current restrictions. We don't really need to go into it much, but really it's meant to show that there's just variability throughout the United States and what businesses are open, who's staying home, who's wearing masks. And so you just have to do the best you can do in your local community. And then this is a picture that the CDF actually, I think, made from a bunch of us at the Barbara Davis Center. But how else do you protect yourself is you get a vaccine as soon as you can. And so we've been fortunate as providers at the BDC to be able to be vaccinated, and we've all been really excited and eager to be vaccinated. And so I want to share with you why we all felt comfortable doing that. And so the question is, should I get a COVID-19 vaccine? And the answer is yes, you should. So in December 2020, the FDA gave emergency use authorizations, and both of the vaccines they did that for have been shown to be really highly effective and really very safe. And people with type 1 diabetes were not excluded from the phase 3 trials. There's been some people I've read that have kind of reported their experiences, and I'm happy to talk about my experience as well. One of the things that I think is really interesting is I was reading actually today and read that somebody who had gotten it said that he experienced low blood sugars for about 4 days after his vaccine. And I actually did too. And I have no idea why that would happen, but so did one of my colleagues that has type 1 diabetes. So I don't know why, but it's interesting that your blood sugars would be lower for the days following vaccination. There's no reason to believe that people with type 1 or other autoimmune diseases would be at increased risk. I know there's been some thoughts going around about that, and really there's nothing to back that. And what we kind of say is, okay, if you have an autoimmune disease and you're likely to be triggered by the vaccine, I mean, it is a risk, like anything you introduce into your body that gets your immune system revved up. You may have a flare or an attack, but it certainly is less risky than getting COVID. So it's just hard when you're making your own decision to do something. And then the adverse effects, like I just said, of getting COVID are far greater. And we generally just recommend to our patients that COVID vaccination should be done when it's their turn in line, but to talk with us if you have questions or concerns. So the two approved vaccines in the United States are these two, the Pfizer one and the Moderna one. And the Pfizer one is approved in 16 and up. They have fully enrolled their pediatric trial, and so they should have their preliminary results in August. And the Moderna one is for 18 and up, and they are still enrolling. They kind of got off to a slow start, so they're still enrolling their participants, and started in December. They're estimated to be done with their study entirely in June of 22, but they'll have some preliminary results earlier than that. I just don't know when. It'll definitely be later than Pfizer. So how do mRNA vaccines work? So when you get the injection, what it's putting into you is messenger RNA. And messenger RNA are like the instructions so that your body can read the instructions and make a protein. And typically a protein has a function, but it has to have a whole body to have a function. So I'll explain a little bit more about COVID here on the next slide. So you get your vaccine, and what happens is the messenger RNA goes into cells, and then you have these ribosomes in your cells that say, oh, okay, thanks for the instructions. I'm going to go ahead. I'm going to translate this into a protein. Thanks for giving me the message. And so they get busy translating it into the protein. And then what happens is the proteins, which in this case are the spike proteins that are found on the COVID-19 virus, are let out into your body. And your innate immune system, meaning your immune system that works right away, attacks that or eats all of that stuff. They're called antigen presenting cells. So they eat it and then they say, whoa, I found some spikes, and wait, these don't belong here. They shouldn't be here. I need to do something about this. And so they go and they present it to the T cell. And when they present it to the T cell's like, what is this? We need to get rid of this. And so the T cell goes and tells the B cells, like, if you ever see this again, you need to mark it with an antibody because I need to know to get rid of it. And then it also messages to another kind of T cell, your killer T cells, to go ahead and just identify that virus and go ahead and destroy it. So your immune system, within 24 hours of getting this mRNA, the mRNA is degraded. And within a few days of making this protein, the protein's all degraded, but your immune system has recognized all of that, and it has made antibodies, and T cells that are hopefully going to be there for a while to protect you. So this is the data from the Pfizer vaccine, and again, it was done in 16 and older, 2 doses, 3 weeks apart. And so you can see the blue line is the group that did not get the vaccine. The red line is the group that did get the vaccine, and down here it's days after the first dose. And so you can see that about 7 days after the first dose, the rate of COVID infections pretty much was nothing for almost the rest of the trial. So if you look overall, out of all the people, 172 in the placebo group had a COVID infection, and 9 of the participants in the vaccine group had an infection after 7 days after dose 2, and none of those were severely ill. And so when you calculate out the statistics for that, that shows that it was about 95% effective at preventing it over the 2-month study. What we've seen at the Barbara Davis Center, where we have followed natural infections and we're following vaccinated people now, is that if you build antibodies, they actually look like they're lasting quite a while if you have a good enough response. So my hope is that this effectiveness will last for much longer. This is from their paper, but I wanted to just put it on here. It's a little confusing. It's the side effect profile. So if you look at the gold boxes, that's the first dose, and it breaks it down by age, so younger and younger. And this is local events and then systemic events. And then the gray boxes are the second dose of younger and then older, over 55. But really the take home point here is that when you get the vaccine, no matter what age, you're going to have pain at your injection site if you get the vaccine. And then the most common side effects that happen, which are down here with the vaccine, are fatigue, headache, chills, and muscle pain, and they're pretty common actually. They happen more often in young people, although I know several people over 55 who have had significant side effects too, but they're short-lived, usually 24 hours or less, and then it's over. And it's just your immune system. Once your T cells are fighting, they release all of these things in your body that cause you to have a little bit of inflammation, and it just, that's what happens when you're responding to the vaccine. The Moderna trial was, again, 18 and over. You can see here that it's a similar story. So if you get the vaccine, very low rate of infection. If you don't get the vaccine, so dose 1, dose 2, the rate of infection continued to go up. And so you can see that starting 2 weeks after your second dose, only 12 people in the COVID vaccine group got the infection, 204 in the placebo group got it. So about 94% efficacy, 93 to 94%. And again, nobody that did get infected was severely ill. And the side effects for Moderna are really very, very similar. So how they broke it down is this is looking at your local side effects, this is looking at your systemic side effects, and it breaks it down into placebo and then the vaccine, placebo meaning just kind of like salt water. And so you can see that with the vaccine, which are these second 2 columns, you have a lot of pain at your site, which is the same thing that was in the Pfizer vaccine. And then over here, you can see that headaches were common, fatigue was common, muscle aches were common. And fever only occurred after the second dose, so really no fevers with the first dose. Okay, so then just moving on to, okay, who's eligible to get the vaccine? So this is the CDC's working group that has given them recommendations. So I'm going to talk about this because from a national level, this is kind of the guidance. However, each state can really do what they want to do. So this is the national guidance, and every state's doing things differently. But basically, phase 1A is in process. It began in December 2020, and that's this light blue group. So it was really healthcare providers and residents of long-term care facilities, so like nursing homes. And then phase 1B is happening in some states already, and that's people over the age of 74, more frontline workers. And then in a lot of different places, including Colorado, which I'll touch on, it's expanded to even more groups. And then 1C is, depending on the state, they say is likely to begin in February or March 2021, and it includes people over the age of 64, anyone else age 16 or above with medical conditions, and all other essential workers. So that's like this dark blue category. And so you can see how many people that is. Then once you get up to phase 1C, now you're talking about 110 million people. And then kind of what's left are the 16 to 64-year-olds without high-risk medical conditions, which right now type 1 diabetes isn't listed. So that's where it puts people with type 1 diabetes. Okay. However, there's a lot of talk about trying to move type 1 diabetes over into the high-risk medical condition group. We know that well-controlled type 1 diabetes on its own doesn't seem to make anyone at more risk of getting sick, like we've talked about. But there's things that go along with type 1 diabetes, like not having access to care when you need it, having high blood sugar levels, having a recent DKA episode. There's all of these things that can make you at higher risk. And because of that, there are a lot of groups that want to move type 1 diabetes from phase 2 to phase 1C. And there's been a letter that was signed by all of these different diabetes organizations, 18 of them, to the CDC, trying to give them recommendations to move type 1 diabetes into the high-risk medical condition group, just so really to advocate for vaccination. And so I guess the websites down here kind of give more information on if you want to advocate. The best advocacy that you can do is actually at a state level, at your local level. And JDRF specifically kind of walks you through how to do that. And so we are making progress. There's been 18.5 million people who've received one or both doses of the vaccine, more than 3 million people who've been fully vaccinated, more than, I think, close to 50 million people worldwide, and then 6.3% of Coloradans have had their first dose, so that's good. In Colorado specifically, our plan is different than the national plan. So you can see that in winter, we're in winter right now, so we're people age 70 and older, a bunch of other essential jobs. And then in the spring, the plan is to start to vaccinate people age 60 and older, as well as people 16 to 59 who have, and it just says diabetes. It doesn't decipher between type 1 and type 2. So my thought is, without knowing any better, it's a complete kind of guess on all of our part, but my thought is that probably adolescents and adults 16 and older will be eligible in the spring as part of phase 2. And this is just from the Colorado website, kind of saying what phase are you in. So if you follow this algorithm, you can kind of see where you fall within phase 1A, phase 1B. Most people with type 1 probably would fall into the not 60, well, could be 60 to 69 or could be 70, but the ones that aren't as old would fall into potentially this higher risk category from just having type 1 diabetes and be eligible in phase 2. And in Colorado specifically, the yellow spots are kind of where they're storing the vaccine and the blue spots are where they're administering it. It's really tricky to figure out where they're doing this. And so in preparation for potentially being eligible in the spring for anyone who's 16 or older, signing up for MyChart is the best thing to do, because all of the healthcare systems in Colorado have MyCharts, and all of them are not, you can sign up for MyChart even if you're not a patient. So Children's, UC Health, SCL, Kaiser doesn't have MyChart, but has a form you can sign up. So whatever state you're in, I would encourage you to look at the different healthcare systems within your state, because usually you don't have to be a patient and you want to try to sign up for all of them, because most of them have a lottery system. And if you're signed up, then when you become eligible, they would automatically put you into that lottery. And I hope that the process gets better, and I think it will between now and when everyone's eligible in the spring, but that's kind of what's going on right now. You can look online at who has vaccines in Colorado. It's a lot of King Soopers and Safeways, and then a lot of employers right now. So with that, I had a couple quotes. I thought it was cute, like there were many to choose from, but Mom, the social distancing thing is awesome. I don't have to wear pants at all this month. And so I think all of us have somewhat, among the things we haven't enjoyed, we've enjoyed not having to do certain things every day to get ready to go wherever we're going. And then I also like this quote because it says, what is the difference between an obstacle and an opportunity? Our attitude toward it. Every opportunity has a difficulty, and every difficulty has an opportunity. And I mean, this is a hard time for sure, but I also think that there are a lot of things that we are learning as we're going through all of this, and that our attitude towards it is what our kids see, and it's what they feel about COVID too. So I would just encourage you all, as hard as it is on the days where it's really hard, to just try to think about what the positives that are going on. And with that,
That was so good. Oh my gosh, like I was sitting here trying to think of questions to ask you, and every time we threw a slide, you already answered the question. So I'm sitting here like usually I have like 15 questions, I'm good to go. The only one I have that I personally want to ask, and if you have any other questions, chat them to me. I will ask them for you. It can be about anything, really, at this point, because she answered so much. But my personal question for you is, if COVID-19 can land me in the hospital, why is it better to risk the vaccine if I have type 1?
sorry, can you say that one more time? It cut out.
Yeah, sorry. If COVID-19 can land me in the hospital, why is it better to risk a vaccine when I have type 1?
Okay, so it can't, so I think, sorry, can you stop my screen share so that I can see you? Is that okay?
Yes,
Okay,
I can do that. Give me 1 second.
thanks. So I think if I heard your question right, I'm sorry it broke up twice, but I think what you're saying is so COVID can put you in the hospital with type 1 diabetes. Is that what you were saying, if it can't?
Mhm. No,
Yeah, so
it can, but why should I get the vaccine if it possibly could have a harmful negative effect as well?
got it. Okay, so if you don't get the vaccine, then like anyone else, you're at least the same amount of risk as anyone else your age of being in the hospital, which is definitely not 0%, or having a bad outcome, which is, not 0% either. If you get the vaccine, the chances of being in the hospital from a COVID infection are, it will happen. Somebody will be in the I mean, we've heard like a couple cases, right, of bad things that have happened, but in general, it's almost 0% chance of having to be in the hospital because of COVID. And the side effects that happen are exceedingly, exceedingly rare. And we're going to hear about every single one of them. But we don't hear about every single case of someone who's had COVID and been in the hospital and been sick, or people who even haven't been in the hospital but have long-standing like GI issues or fatigue or mental fogginess, things that are very real and last for a really long time.
Mhm. Okay, that was great. Does anyone else have a question? I'll wait 2 seconds. What was your experience? I will ask this too, post-vaccine, since you do have type 1.
So with the first one, I had tenderness at the injection site, like probably, I got it in the morning and that night I had tenderness. And then the next couple days, my blood sugars were low for no reason. Like my insulin decreased by 25%. And the person I read today said 30%. And my colleague showed me that she was just like eating all day and barely hovering at 70. So
Wow.
I have no idea what that's about, but or if it's real, it might just be a total coincidence. But and then at about day 3, 4, I actually had this just very mild headache that wasn't a normal headache, and a little bit of nausea where I didn't really feel hungry. And that lasted 2 days and went away. Second dose of the vaccine, I got, and about 14 hours after I got it, I felt like I kind of had a fever and the flu. I didn't. My temperature was 99.4 though, which is higher than normal. And so I just kind of like tossed and turned. And then by the time I woke up in the morning, I could tell whatever it was kind of had broke, like I felt fine. And then I had a little bit of a headache and a little bit of kind of GI upset for a couple days. So.
Gotcha. Okay, Dana has a fun question. I'm going to read it for her. If I am on a med that destroys B cells, how effective will the vaccine be?
Yeah, I think that's a really good question. So I don't think we know, because we don't have enough people in the trials that have been on immunomodulatory medications to really know. But I think that just because you have B cells that can't make antibodies or can't work, assuming that the medication is doing that, then that doesn't mean that your immune system can't still ramp up a response, because you still have the T cells that have taught the cytotoxic T cells to recognize the virus and get rid of it. So you have you have your immune system primed. You maybe don't have all of it ready, and the antibodies may be one of the more important parts. I don't think we even know that for sure, but you at least have something that's going on with your immune system. And I think the same question to another extent with people on immunosuppressants, we don't know how much of an immune response can you mount in response to the vaccine, and will it be protective? But I think the data I've looked at so far shows that it should do something, maybe not as efficacious, but something.
Thank you.
And then another question, when vaccines are available for our 16 and older type 1 kiddos, will we go to Children's for the vaccine?
Yeah, so I don't think we'll know until they're ready. Well, I hope maybe we'll know in advance, but so far it's been we don't know until it's like the day that things are happening. I really do think that Children's will have vaccines for kids. They just advocate for that, and I know that they've been working really hard to try to be a site that would have vaccines. And I would anticipate, because they've already done it with all of the, a lot of the Children's employees, that they already have a system in place. And so I think they'll probably use MyChart, and that you'll probably schedule through MyChart. And so that's why I would just make sure to sign up for a Children's MyChart account if you don't have one, so that you're ready to go if it's announced.
Perfect. And then Melinda, I saw you have a question. I don't quite understand. Are you able to hop on and ask it yourself? If not, I could try to read it. Okay, doesn't look like it. So her question was, for T1D patients under the age of 12, what is the recommendation until a vaccine is available, potentially 2022?
Yeah. So I think kids that are that young are at the same risk as their peers, which doesn't mean that, so kids get COVID. I think the message came out earlier that it was like, oh, kids don't get it. Like they don't get it, they don't spread it. They do get it, and they do spread it. And it's very clear that happens. However, as far as the data goes, kids usually, if they're following precautions like they do at school with masking and distancing, they don't usually spread it there. And there's, identification of cases and appropriate quarantining, I guess, but it gets spread in social situations where people aren't being careful. And so, my personal thought is that you don't want to be one of the rare kids who does have a side effect from getting COVID. And I definitely have a few patients where I've seen some things. So they're rare, but they're there. And so I think that you just need to try to practice your social hygiene as much as you can, making sure you're washing hands, making sure you're wearing masks when you're out and about or around people. And then hopefully, if you are eligible to be vaccinated, before them getting vaccinated, because even though we don't have data right now to show that it decreases that you decrease transmission by being vaccinated, there's absolutely like no way in my mind that that's not what's going to happen. I think if you're vaccinated, you also probably can't spread the virus nearly as much. So that's just how vaccines work, and that's how your immune system works. So I think those are the things. I wish we could just say there, we didn't have to do any of that stuff anymore, but it's going to be a little bit, it's just going to take a while, and I know it's hard.
Awesome. Okay, we have 2 more questions just came in. The next one is, do you think children with T1D who are between ages of 12 and 16 will be able to get the vaccine in the fall?
I think that probably, if their results are going to be in August and they go for emergency use authorization, that usually takes 30 days, within 30 days. So that puts you the end of September, and then you hope by that point that their system's in place to be ready. So I would say probably more looking at like late fall, early winter would be my guess.
Okay. Are double masks truly better, or is one just okay?
Yeah, so I've only read a couple things about that, and both the things I read actually convinced me that it probably is better, but I haven't decided whether I'm personally double masking it. It sounds like a lot of work. So, but
Fair
yeah,
enough.
it makes sense. It just provides it provides another layer. I think though the other problem is that there's some data showing that if you wear another mask, depending on what the materials are of the 2 masks, you could decrease how one of the masks works. And so I don't know. I need to read more about it. I'm sorry, I can't completely answer your question right now, but I think if you wear one mask and it's, you know, a decent mask that you're wearing correctly, so like not a net gaiter, but an actual mask, and you're practicing decent distancing, and you're not like going to a big crowded party, that you should be okay.
Perfect. All right. And then are T1D kids at increased risk for MIS-C, the multi-inflammatory syndrome that is rare?
So far in the United States, we have not seen any kid with type 1 diabetes who has had MIS-C. There is one kid that had an illness that looked very, very much like MIS-C, who had type 1 diabetes, but did not have COVID antibodies. So, you know, that could just be that the testing wasn't good enough. So if anything, one in the whole United States. So I would say no. I would say probably not any more risk than anybody else.
Okay. Last questions for anyone else? That was wonderful. Thank you, everybody who asked questions. I do appreciate it. It's not just me sitting here staring at all of you. Okay. Then I am going to stop this recording. You guys are all welcome to leave, but thank you so much for joining us. We hope to have a digital support group once every month. You will all get emails from me talking about when those are, what's that all about, that kind of thing. But any questions, feel free to shoot me an email. Thank you, Dr. Simmons. That was wonderful. And you definitely set the bar for other presenters. So well done.
Thanks for coming.
Awesome.